Can I raise an issue, please, Chair?
Please, go ahead.
Yeah, very briefly, I just want to raise the issue of the decision by NIAC yesterday in relation to AstraZeneca. Obviously, it's a matter for them in terms of the public health measure and putting safety first, so I have no problem with that. It's more the implications of that decision, and we need to hear from the HSE and from NIAC next week that they have a plan to mitigate against this decision, because we don't want this to in any way interrupt the rollout. We know how important the vaccine rollout is going to be. We're going to deal with this issue in this session as well with NPHET in relation to the impact that the rollout will have on allowing us to make decisions on reopenings, on outdoor dining, for example, and outdoor activities. So this is very important. And I have to say, and just I can finish on this, Coherlock, I'm not satisfied at all with the responses that we've got from the Minister for Health in the Dáil chamber over the last number of weeks. He's not presenting a plan. He's not presenting us with timeframes. He's not presenting us with targets. We have the HSE next week, and we have NIAC, and they need to come in with a plan. So I'm asking in advance of this hearing next week that we write to them and ask them for a very detailed note and a plan that assures us that we can mitigate against this, because it's obviously a serious development. And when we have them in next week, they need to be coming in with a plan. And need to give us that in advance of the hearing. Thank you.
I don't want to open a debate on it, but Martin, I see you have your hand up, but can you...
Just quickly to endorse David's proposal in the first instance, but also, Chairman, since NIAC are coming in and the HSE, particularly I suppose the HSE, I'm very concerned about the HPV rollout of that vaccine, and I think that we need to get an update on that as well, and if there's any proposal to have a catch-up programme, given the fact that schools have been closed now a significant period of the last 12 months. I have dealt with a couple of parents who are trying to get their children the HPV vaccine, and they're being told it'll cost them something in the region of €500. Now, this particular programme, catch-up programme, was ran successfully in 2018, and I think we need another one. So if they could be just alerted to the need to come in and give us an update on that as well, I'd appreciate it.
Okay, I think there's general agreement on that. I know Roisin has her hand up and
Chair.
Yes. Roisin.
Chair.
Yes.
Yeah, I'm just saying, is this not the purpose of the private meeting this afternoon, to discuss all these other issues?
Yes. But
well,
NPHET are waiting. Can we start the meeting?
Hang on a second. The matter was raised, and I was quite entitled to come in as well. So I actually resent that comment.
Can Bernard, is it the same issue?
It is on the same issue, Chairman. If I might, for a minute, just a word of caution. I am worried that we're going to run down a road of chasing the virus, and that's something over which we have no control, and which the HSE has no control over either, because that's all down to one thing: supply. And if the people don't supply, or are not capable of supplying, or if there's a safety issue involved, what are we going to do? Are we going to superimpose ourselves between the HSE and the general public and set ourselves up as the people to go to in the case of concern? And if something goes wrong, and there's a health issue, and there's an inquiry into it, are we going to take responsibility for that? Because there's an area there we need to be very, very careful about. It's all very fine criticising the minister and so on and so forth, and I'm sure the minister is well able to look after himself. But I want to point out this, that we are not the experts in that area.
No,
and we shouldn't pretend to be.
But as has been pointed out, we can raise this at the private meeting, and we do have them coming in to us. So I want to move on and introduce our witnesses. I'd like to welcome our witnesses to our meeting this afternoon from the National Public Health Emergency Team, NPHET. They'll be presenting virtually to our meeting and provide us with an update of where we are in relation to tackling the COVID-19 pandemic. From NPHET, we have Dr. Ronan Glynn, Deputy Chief Medical Officer. Ronan, during this session, will you sort of direct, if you some of the members want to come in, will you direct them? Jerry O'Brien, Director of Health Protection Division, Department of Health, and Professor Philip Nolan, President, Maynooth University. So if you can help me out there, Ronan, in relation to that, direct me to who you think should be responding to the question. So you're all very welcome to this afternoon's meeting. A bit of advice on parliamentary privilege. Before we hear your opening statement, I need to point out to our witnesses that there's uncertainty of parliamentary privilege will apply to your evidence from a location outside of the parliamentary precincts of Leinster House. Therefore, if you're directed by me to cease giving evidence in relation to a particular matter, you must respect that direction. So can I now call on Dr. Glynn to make your opening remarks, and you have 5 minutes. You're very welcome. Ronan.
Thank you very much, Chair. Can you hear me okay?
Yes, loud and clear. Thanks very much.
So thanks to yourself and to the members of the committee for the invitation to update you on the COVID response today. I am joined by Professor Philip Nolan, who's the chair of our modelling group, and by Mr. Jerry O'Brien, who's the director of the Health Protection Division here at the Department of Health. The public health strategy for addressing COVID-19 is comprehensive and it is continually being strengthened. I will provide an overview of the current epidemiological status and recent developments in our response. We have more reasons to be hopeful now than at any time in the pandemic to date. Firstly, our national vaccine programme is well underway. Last week, Ireland reached the milestone of 1 million vaccines administered. As of Saturday, 19% of Ireland's adult population have had at least one dose of COVID-19 vaccine, and 8% of adults, including those most vulnerable in our population, are fully protected. The positive impact is already being felt. The percentage of COVID-19 cases in healthcare workers, for example, has been decreasing significantly and is down from 10% of all cases notified at the start of December to less than 2% of cases over the past 14 days. Secondly, we are seeing good progress in the trajectory of the disease. Our most recent data up to midnight on the 11th of April shows that the 14-day incidence decreased to 132 per 100,000 population, a reduction of 15% from the previous week. The 5-day moving average of new cases reduced to 404, a reduction of 23% from the previous week. Case numbers reported on Sunday were the lowest reported since mid-December. This is further proof that our collective efforts continue to make a real difference. The average number of close contacts has held remarkably low and steady over the last month, and this is proving critical to preventing the spread of the virus. Hospital and intensive care numbers are also moving in the right direction. As of this morning, there were 206 COVID patients in acute hospitals. 48 of these were in ICU, and this is the first time the number of people in critical care has been less than 50 since New Year's Day. Finally, we've seen a dramatic reduction in the numbers dying with this disease. At the end of January 2021, the average number of deaths being reported over a 7-day period was 49 per day. By the end of March, it was down to 8 deaths per day. Thirdly, we have resumed our priority public services. Schools returned in full yesterday. Childcare fully resumed at the end of last month, and the HPC has a comprehensive plan in place for the full resumption of non-COVID health and social care services over the course of this year. We shouldn't underestimate this achievement. Schools remain closed across many EU countries, and healthcare systems across the continent are currently under immense pressure. We have also taken our first steps this week on what will hopefully be a steady pathway to reopening our economy and society. Further measures will ease later in the month, enabling more outdoor activities and socialisation in order to improve the health and well-being of society. All of this means that we can be hopeful of a return to better and more normal times. However, while significant progress is being made in controlling the disease and in rolling out vaccines, we still have a high level of infection. We are dealing with a much more transmissible virus than last year, and the absolute number of people fully vaccinated or fully protected through vaccination remains low. This means that there remains considerable risk that Ireland will experience a further wave of infection if public health measures are eased too quickly. However, modelling has shown that a further wave of infection can be substantially mitigated if levels of social contact across the population remain largely unchanged over the next 6 weeks. The priority must, for the coming weeks, remain on maintaining control over this disease until vaccination can offer a widespread population level of protection. NPHET advice to government continues to recommend a cautious approach, and that any further easing of measures should be gradual and phased and should allow adequate time between phases to assess the impact. Our priorities also remain the same: to protect the most vulnerable, to facilitate the safe return of in-school education and childcare services, and to resume non-COVID health and social care. The NPHET will continue to monitor the epidemiological situation closely over the coming weeks to assess the impact of the reopening of priority services and those measures that have been eased. NPHET and the Government will consider the position again at the beginning of May. We are also continually strengthening key elements of our response to ensure we have comprehensive systems for preventing and containing transmission of this virus. The HSE has already developed significant capacity and capability across its testing and contact tracing service, and a range of further enhancements have been recently implemented. These include the introduction of walk-in testing centres in high-incidence areas where asymptomatic people can get a test free of charge, the expansion of source investigation to identify where transmission may have occurred in more cases, and the further rollout of rapid antigen testing pilot studies. Significant steps have also been taken to strengthen measures in relation to international travel. As I've already mentioned, many countries continue to struggle with high levels of infection, and there are already a number of variants of this virus that causes great concern. Again, it is important that we don't risk the progress we are making nationally by exposing ourselves to variants that may have serious consequences for the impact of our vaccination programme. But we must be careful that we don't consider any one of the above measures as a panacea. Our consistent message throughout the pandemic has been that a combination or layering of measures is the most effective means of controlling this disease. And the most effective measures of all are those that we can take ourselves: wearing a face mask, keeping our distance, practicing good hand hygiene, keeping indoor spaces well ventilated, and isolating and presenting for testing if you have any symptoms. To conclude, while we now have very tangible reasons for hope, we must continue together to move cautiously over the coming weeks to ensure that we protect the significant gains we have made over the last number of months, and to allow us time to protect more people, particularly the most vulnerable, through vaccination. Despite the very understandable levels of fatigue, we know that the level of support for public health remains high. The efforts of the vast majority of the population are continuing to help to suppress viral transmission in our communities. I thank the public, and in particular our healthcare workers, for their ongoing support. My hope is that we will never again have to recommend more restrictive measures. However, to achieve this, we must continue to hold the line in the coming weeks as our vaccine programme ramps up. Thank you, Chair.
Thank you, Ronan. Again, can I advise members to stick to the time allocated? So our first question is Sean Coyne.
Thank you, Chair. I'd like to welcome Dr. Glynn and the team here this afternoon. Dr. Glynn, vaccine hesitancy is something that could creep into the population with the decision of NIAC and AstraZeneca. Are you concerned about this, and should we be looking at getting increased supplies of other brands of vaccine to combat this? And I note this afternoon the decision of the US FDA to recommend a pause of the Johnson & Johnson COVID vaccine so it can investigate reports of blood clots. Are you concerned about vaccine hesitancy? Linked to this, in the UK there is presently the biggest surge testing operation to date, as dozens of the South African variant cases are found in South London. Israel have reported this variant can break through the Pfizer-BioNTech vaccine protection. Has the South African variant reached our shores on the island of Ireland, and what are the consequences if it does? Early results from France show huge potential from the Valneva vaccine. Unbelievable results according to Professor Luke O'Neill. And are you engaging with the French counterparts on this? And finally, we look across the water at the UK situation and pubs and restaurants reopening. Have you, based on today's information, any information or roadmap on when the hospitality sector might reopen here and in what form that reopening should take place? Businesses need to be able to plan, and again, this balance between opening the economy and health concerns.
Thanks, Sean.
Thank you. To your question on vaccine hesitancy, yes, we're obviously always concerned about vaccine hesitancy, and whilst that's been, I suppose, less of a concern over the first number of months of rollout, in that anyone who gets a vaccine or who's offered a vaccine, I think, has been very keen to avail of it. We have been aware, obviously, of the need to maintain levels of confidence in the programme, and to be honest, that's been a key component of the approach that we've taken. We've tried to be proactive in assessing the latest data, in communicating that, in ensuring that the public understand the rationale for decisions and that they understand that safety comes first. in relation to our decisions. And I think it's thanks to the work of NIAC and the work of colleagues in the HPRA and across agencies that still, despite what has been a bumpy road, not alone in Ireland, but internationally in relation to these vaccines, still in Ireland, almost 9 out of 10 people say they will probably or definitely take a vaccine when it is offered to them. Clearly, we can't take that level of confidence for granted. Clearly, we have to continue to communicate and address concerns. As I've said on many occasions, there will be 20 or 30% of the population who will have very legitimate questions, very legitimate concerns. We need to continue to address those. And in particular, we need to address concerns of maybe vulnerable communities, hard to reach groups over time to ensure that we see equitable access and equitable uptake as the vaccines are rolled out. To the second question, the South African variant, yes, we've had 46 cases of that, of the variant that was first reported in South Africa. We've had 46 cases of that reported here to date. We are concerned about levels of variants, either actual levels in the country now or potentially increasing levels of those variants over time. And in particular, we're concerned about their potential impact on the effectiveness of vaccines and the potential, were they to spread, for them to have a detrimental impact on what we want to do in terms of easing measures across society over the coming months. Thankfully, at the moment, the numbers are low, but we need to keep them. We need to keep them low. And as you have indicated in the UK and indeed here, that necessitates a very robust and comprehensive public health response each time one of these cases has been identified. And we have had very robust responses from our public health doctors for a number of months now around these variants as they've been identified. And indeed, guidance around that response was brought to NEFIT again, updated guidance brought to NEFIT last week and endorsed. And the HSE is in the process of operationalising that. On the issue of hospitality, I can't speak to that, and I understand that it'll leave many of you frustrated, but I'm not going to speak to specific measures that may or may not happen over the coming months. We will look at the data over the next 2 to 3 weeks, and we'll provide updated advice again to government at the end of April. And the intention is that we will provide a roadmap from there for May and June and onwards. That's subject, obviously, to the disease remaining stable or indeed continuing to improve over the next couple of weeks. But clearly, there's a need for a plan. People need to know what's coming and the broad parameters for when they can expect various measures to ease. So let's see what the next couple of weeks bring. Clearly, the last week was very positive in terms of the disease, but that was in the context of the Easter break, and we just need to see what a normal week looks like this week.
Okay, thank you, Dr. Glynn. Could I ask in relation to the, as said, the US Food and Drug Administration recommending a pause of the Johnson & Johnson vaccine just this afternoon to investigate reports of blood clots? Have you any comment on that? And also, as I said, the French vaccine Valneva. And could I just make one comment then in relation to, obviously some of the basic messaging around hand hygiene has been hugely important, but I believe anecdotally and from reports around the country, I think the practice is being reduced of hand sanitizing, certainly in shops. I've seen it in places. I've seen it in the shop here in Dublin where there was no hand sanitizer available for about certainly 3 weeks. There was subsequently. I've seen it in service stations where you have to go looking for a hand sanitizer. It should be in your face. It should be in your line of vision. I believe, better and improved and newer signage would be necessary to again remind people of the importance of hand sanitizing, of preventing COVID, particularly with new variants, and particularly, the other things, the other benefits of good hand hygiene in terms of other diseases as well. So maybe you could comment on those few questions.
Sure. So just on Valneva, my understanding is that whilst the initial results are promising, we don't yet have sufficient data in terms of authorization, but of course we want to use any vaccine that comes through that's shown to be safe and effective. So colleagues here in the department will continue to monitor that. In relation to the news on the Johnson & Johnson vaccine from the US, I'm aware that the EMA is monitoring the situation. And so after this meeting, like it literally came out as I came on this call, I'll be liaising with the HPRA to get an update. But I know that the EMA has been monitoring that situation. In relation to your last point, I would fully endorse the need to re-emphasise and strengthen and improve the messaging around the basic measures, because regardless of what happens with vaccination over the coming 6 weeks, 2 months, 3 months, it is those basic measures that will allow us to ease up on the measures that are much more important to us at a societal level. So absolutely, and I know there's been talk that fomite transmission, or transmission you get by touching surfaces, is less of an issue than we previously thought. But Cillian de Gascon is pretty clear that the science is not as clear as some would have you suggest, that we no longer need to worry about that form of transmission. So it's not one panacea. I think we should be still having a very, very strong emphasis on hand hygiene. The signage going into parks, the signage going into shops could all be refreshed and updated. We need ongoing messaging around the importance of ventilation and all of the other measures around keeping your distance, wearing a mask. If we can continue to do those measures as a society, all of that will allow us much more options through the summer in terms of what we can open up in terms of sectors and society more broadly, if we can keep those basic measures going.
Last minute, Sean.
Yeah, just one final question. In terms of that monitoring of, whether it be businesses, whether it be shops, in terms of ensuring that they have, as I said, basic supply of hand sanitizer, for example, whose role is that in terms of ensuring that a shop complies with what we have known for the last year to be hugely important and to be one of the core messages from NPHET and enhanced by government, or advocated by government?
Well, certainly we can. NPHET can certainly advocate for that more broadly, and message that it is what we would like to see from the various sectors, and we can communicate with colleagues across government. I suppose in many instances the measures taken by individual retailers or individual businesses across the country have been done on a voluntary basis and on the basis of buying into the need to protect one another. And I would hope that would continue, and that people would see the value in doing that as a contribution to the wider efforts to reduce transmission. But I do take your point that perhaps we need to more vocally stress the need for the basic measures to be strengthened and refreshed and continued over the coming months.
Thank you.
Thank you, Dr. Glenn.
Thank you. David Cullinan.
Thank you. First of all, welcome Dr. Glynn, and I want to commend you and your team for the work that you continue to do, and to wish you well in the time ahead. I know it's difficult for everybody, and you acknowledge in your opening statement the difficulties all of this poses for the general population. And you also acknowledge in your opening statement, which I think is very significant and important, that we have more reasons to be hopeful now than at any time during the pandemic. And you go on to say that we can be hopeful of a return to better and more normal times, which obviously we all want to see. And you clearly set out then the ingredients which will lead us to a better place in terms of test and trace, travel checks, the vaccine rollout, and the current restrictions continuing. So I just want to put a number of questions to you in relation to all of that. So you said earlier you don't want to talk about specific easing of measures that might be possible in the short term. And I assume that you don't want to speculate at this point in time, and that you will continue to evaluate the data as it emerges over the next number of weeks. You also say in your opening statement that if levels of social contact across the population remain largely unchanged over the next 6 weeks, then we'll be in a position again to reevaluate issues. So can I ask, first of all, is that where we're at? Is it NPHET's position at this point in time that the current level of restrictions which are in place will remain in place for the next 6 weeks? Or is there the possibility of additional changes within that 6 week period?
There is. So I think that the one line from my opening statement was probably misinterpreted in some quarters this morning. So first of all, I hope that my opening statement is first and foremost a hopeful message, as opposed to one that's warning about a fourth wave. We're not predicting a fourth wave. We're simply saying that it remains a possibility, whilst also acknowledging that the vast majority of indicators appear to be going in the right direction.
So what I was asking Mr. Glynn is, within that 6-week period, there is now the possibility of a further easing of restrictions.
Absolutely. So our intention is to review the data again with a view towards what easing might be possible in May. We will do that at the end of this month, and we'll provide updated advice to government in that regard. But that,
can I ask, in terms of the broad parameters that you spoke about, and I know you don't want to go into specifics, but the obvious areas would be outdoor activities, sport. I know outdoor dining and hospitality is mentioned as well. Can you give us some indication of, in general terms, what areas we can be expecting to see some movement on in that 6-week period before I move on to post that 6-week period? So people want, as you said, hope. And if you can give us maybe some indication, without being overly specific, if that's what you cannot do, in relation to what we can expect.
So I think the government has already set out in its most recent update, I suppose, a number of areas that they would wish to look at, and I think we would be looking at those areas in particular, such as, for example, click and collect, non-essential retail, further easing in terms of outdoor sports and training, measures like that, and then I suppose outdoor businesses, and then moving on from there. But again, I would hope that by the end of this month we'll be able to set out a plan, or at least an indicative high-level approach that we can hopefully adhere to over the following 6 to 8 weeks, that will bring us through May, through June and into July.
And I think that's very helpful, Mr. Glynn. But can I say that if we take outdoor dining and outdoor events as, and certainly from a business perspective, as one of the options, there needs to be a lead-in time. So there needs to be some heads up given to those businesses that they can prepare. So I know that you will accept that, and if that can be factored in. I just want to talk, if I can, and maybe expand on modelling that NEFID may have done in relation to the vaccine rollout and the relationship between the vaccine rollout and our ability to ease restrictions. So what milestones do we need to reach in relation to the vaccine rollout that will allow us to significantly ease restrictions? Because in the letter that you sent to the Minister for Health on the 29th of March, you said that the vaccine rollout gives real hope that there can be a much more widespread easing of measures during the summer months. So widespread is obviously significant. So what milestones in the vaccination rollout, in your view, what staging posts need to be reached that will be significant, that will allow you to make more decisions in relation to easing restrictions?
So I might ask Professor Nolan to come in a second, but I would say just two broad things, that the benefits that can be accrued from the rollout at any point in time depends on where we are with the disease at a point in time. So if we can continue to keep this disease under control over the next couple of months, and we have a significant proportion of the population vaccinated, that will give us much greater options than if it gets out of control and we're coming off another.
But my point, Mr. Glynn, is for us to be hopeful, and for people listening, and you acknowledge the frustration. People also want to know, what are the milestones, what are the staging posts that we need to reach? But I can just, before you bring in Professor Nolan, add an additional point that was made in that letter you gave to the Minister for Health. He said that vaccination will significantly and quickly reduce risk over a short period of time, from May 2021 to August 2021. And you say that it will reduce mortality when those over 70 are fully vaccinated, but will initially have a smaller effect on hospitalisation and critical care until the wider adult population, especially vulnerable adults and those aged 50 to 69 years, are protected. So I suppose my point is that the type of staging post or milestone that we have to reach? Are they the type of numbers of people that we need to see vaccinated before we can see what you call widespread easing of restrictions?
So I might invite Professor Nolan in.
Thank you.
Yeah, I think it's important to look at it in two ways. The reduction of mortality risk, like the risk of people dying. So there's an important milestone when people over 70 are effectively protected. And at that point, you see a radical reduction in the likelihood of people dying. People younger than 70, some of them remain at risk. mortality, and there's a much wider risk of hospitalisation. But the effect of vaccination is progressive. If half the adult population were vaccinated, the virus would find it twice as difficult to transmit. So I don't think we
Sorry,
should...
can I just ask Mr. Nolan, because my question is, and I need to know if NEFID or you have done modelling in relation to various stages in the vaccination programme and linking that to easing restrictions. So have you, for example, looked at if we get 50% of the adult population, here's what's possible. If we get the medically vulnerable and all the over 55s, here's what's possible. Is that modelling done? And is that something that informs? I know there's other issues in relation to deaths and hospitalisations in ICU, but specifically the vaccine. Have you done the modelling in relation to those type of issues? And the question I'm asking, so is there milestones that NEFID can see, if we reach this, we have an opportunity to ease restrictions? And can you inform the public of that if that is the case?
So what we've modelled is the current vaccination programme, and if people are vaccinated according to the programme as published, and obviously we rerun the models on the basis of recent decisions. But the fundamental thing that model shows is that we shouldn't be thinking about it as benchmarks of 25% or 50% or 75% of the population vaccinated, and then we can do one big thing. What the model shows is that the impact of vaccination is progressive, so that the more people that are vaccinated, the harder and harder it is for the virus to transmit. Ultimately, one might get to the point of herd immunity, where the virus can't transmit and sustain the epidemic. But far in advance of that, you begin to find fewer cases.
Sorry, Professor Nolan, because we have short time. I wasn't specifically even talking about percentages of the population. I'm talking about whether it's by age cohort or whether it's by people with underlying conditions. That's my point. So is there benchmarking or targets that you would see or staging posts that if we achieve this, we're in a better position here? Because obviously Dr. Glynn is talking about over the next 6 weeks the possibility of more easing of restrictions, and then beyond that there'll hopefully be further easing, and the vaccine rollout would be central to that. So is that level of modelling, can that be shared with the Health Committee, what modelling you have done on some of that?
Yeah, a lot of it is in the letter, but as I say, and I'm not avoiding the question. The truth is it's progressive, and it's rapidly progressive. There aren't actually milestones, and if you look at the layout of the vaccination programme, the rate at which the population is vaccinated ramps up very quickly over a short number of weeks. So one goes from 25% to 50% to 75% of the population effectively vaccinated over the course of less than 12 weeks in the shape of the current programme. So,
okay, I have that, and thanks for that, Professor Rollout. One last question I want to put to Mr.
You've run out of time, David.
Just one last question, if I can, Chair. You talked earlier about the concern about new variants. Can I just ask you, how important is it that we continue with travel checks and mandatory quarantine? So where does NEFID stand on that in relation to your concern about new variants? If you could just quickly give a response to that question, please. Thank you.
Yeah, it's a key part of our response, and I suppose just to be clear, it's a key part of our response in the short term in particular. I hope that we would see a rapidly improving situation, particularly across Europe, as they step up their vaccine over the next 6 to 8 weeks as well. But I think at least for the next 6 to 8 weeks, we need to do all we can to keep this disease on island under control, and to prevent the introduction of, we will not prevent the introduction of all variants, but what we need to do is minimise that to the greatest extent possible.
Thanks very much. Thank you. And again, following up from that question, is the possibility of, extending that modelling criteria that you're actually using, because again, that would be useful for the committee in its own deliberation. So our next questioner is John Lahart.
Thanks, Chair. I have 10 minutes, yeah?
Yep.
Thanks, professors, and for your work. And I'm sorry that time doesn't allow us to be more effusive than that, but you can take it that we very much appreciate the work that you're doing. And certainly I speak for myself. We've learned from the I won't say the mistakes. There's been significant learning since before Christmas, and I think everybody gets the caution and the slow the gradual approach and that it's working, and it's tedious for the public, but we get that. I think the body politic gets that, and I think the public increasingly get it. That is not to say, obviously, that there are businesses and lives out there being devastated as we speak. Some quick fire questions. Just when will pharmacists begin vaccinating?
I think that question, I think, will need to be answered by the HSE. And I believe they're in next week on vaccine rollout.
Okay. You can't shed any light on it.
I don't have the detail, I'm afraid. Sorry, Deputy.
Okay. I'm just starting my own timer there. Can you name the variants of concern? Are there any ones that we haven't heard of? So there's the Brazilian, the obviously B117 and the South African.
Well, they're the primary. You see, the primary ones that we're monitoring and concerned about are P1, which is the one identified in Brazil, B1351, which is the one first identified in South Africa. Just to be clear, we are concerned about B117, which is the one we have dominant in this country, because there are mutations, further mutations of B117 now emerging internationally, and we have 1 or 2 cases also here of that with additional mutations. There's a P2, a P3 from the States, or first identified in the States is a B1525, B1526. So there's a whole range of variants of concern and variants under investigation. But the principal ones that we have here at present, in terms of just the numbers of them, would be P1 and B1351.
Okay, thanks for that. How many people have been fully vaccinated with the Astrozeneca vaccine?
I might ask Mr. O'Brien to come in on that.
Might stop the clock, Chair.
Good morning, everybody. The AstraZeneca vaccine, there's been 235,000 first doses, 235,000 doses given with AstraZeneca.
Yeah. How many people have been fully vaccinated with AstraZeneca?
But due to the 12-week window between vaccinations, I don't believe there's been any second doses at this stage.
Okay, thanks for that. So, like, according to, we'll say, the preliminary, the draft programme or calendar that the government has, you know, we were looking at 3.9 million vaccines to have been administered by the end of June. And look, hopefully that happens. That's not my question. So we'll say, just going on the present ratio we see on the app every day, it's kind of somewhere between a ratio of 2.5 to 1 of first vaccinations as opposed to fully vaccinated. So that would mean there would be, if everything went to plan, please God it does, that there would be 1 million people fully vaccinated by the end of June. What can they expect to do if they're fully vaccinated?
So I would look at it in a slightly different way, if that's okay, and I've reiterated this target on a number of occasions, which is that if we can get approximately 80% of the adult population with at least 1 dose by the end of June, and if the disease is under control at that point, I would hope that we would see a far greater level of society open than where we are at this point. And at that point, I would hope that there wouldn't be an undue need on Ireland to differentiate between, for example, what you can do if you've been vaccinated and what you can do if you can't. So, for example, there's been some suggestion that, well, maybe you can go and get a haircut if you're vaccinated. I'd hope that long before that, if the disease remains under control, everyone will be able to go and get vaccinated because the disease is under control.
Okay, so back to the Johnson & Johnson. Well, that's good news, and look, people will be seeking for you to flesh that out, I'm sure, further speakers, so I leave that to them. So in relation to Johnson & Johnson, because we're due to get 600,000 of those, which is essentially 1.2 million of an AstraZeneca equivalent or 2-jab equivalent. So we know about the USA that they've paused that, and we know that the Australian government said on Tuesday that they wouldn't purchase Johnson & Johnson. What reaction have you got to that?
I'm afraid I'm not in a position to say too much about it at the moment. Like the report from the States literally came out as we joined this meeting. I do know that they're reporting 6 cases out of 7 million vaccine doses given. So I'll need to look at further information on that through the day. I'll need to liaise with the HPRA, see what the EMA position is on it.
Okay. I just want to add my voice to the signage and all of that. Everybody, whoever the contributors and stakeholders are in that, it's become wallpaper. It became wallpaper 6 months ago. And I think that can be revisited to refresh it in terms of reinforcing the caution and the messaging. One of the restrictions that was eased was that allowing 2 fully vaccinated people can meet indoors, isn't that correct? And have a chat and a cup of coffee or whatever. Yep.
Yeah.
Okay, so what I don't get is this, because I've had constituents who live here, who may have been working under contract abroad, have been fully vaccinated. I absolutely support hotel quarantine. But if you're fully vaccinated and quite willing to quarantine at home here, because you have a house here, why should we insist that someone who's fully vaccinated, given that we allow 2 people here who are fully vaccinated meet each other, why do we insist on people who are coming in from abroad who are fully vaccinated, why do we insist that they are hotel quarantined?
So there's a variety of reasons that collectively make up the answer. So first and foremost, we're still not entirely clear what impact a vaccine or different vaccines have on transmission of the virus. So you can be vaccinated yourself and carry one of these variants of concern and bring it into this country and give it to somebody.
So that makes sense then about 2 vaccinated people being allowed to meet, because obviously they're both vaccinated.
Well, they're both vaccinated.
Yeah.
They're also both vaccinated here in this country, where as things currently stand, we don't have an undue level of variant of concern transmission in the community.
Okay.
In any event, no vaccine is 100% effective for 100% of recipients.
Okay, so it's the variant, I get that, yep, okay.
Different vaccines can have different impacts on the issue of transmission, and we do need to learn more about that over the coming weeks.
Okay.
Different variants will have different effects on different vaccines, and we are seeing increasing reports now on a daily, certainly a weekly basis internationally, of cases and clusters arising in people who've been fully vaccinated, cases particularly with the B1351, the South African variant.
Okay.
There's still a question as to the length of immunity that's afforded, or the length of protection that's afforded by vaccine-induced immunity. And then there's the whole issue of certification and our ability to stand over the validity or to authenticate.
Okay. I'm going to stop you there, Ronan. That's very comprehensive, and actually a paper on that to us, a brief paper on that to us, would be really useful, because the question that often comes up from constituents. And final question, and look, it is in relation to constituents. GPs have had calls this morning. Politicians have had emails and calls over the last 24 hours from concerned, and I'm sure you've had the fair share of email, and it's been all over the radio, about people who are now anxious about taking the Astrozenica vaccine. So my question to you is this, because a lot of it has been covered, and you did cover, I listened into you live last night, like you covered as much as you can, but the thing is that the cattle have been spooked, to use that Western movie analogy. If someone, because the line coming out in NPHET, and I do understand this, is that one should take the vaccine that you're offered. But if someone, has serious reservations about that, shouldn't they, don't you think, be allowed to exercise those reservations, just as there are those who don't want to take the vaccine, and that they shouldn't be, and I say inverted commas, punished by having to wait then, particularly in the over 70s or the over 60s, in vulnerable, because they are the vulnerable positions. Should they not be in a position where they are able to receive the vaccine, a vaccine, regardless of whether it's AstraZeneca or not, as quickly as possible, and in an ideal situation, in the order in which they were intended to? That's my final question. Thanks, Chair, and thanks to the witness.
So I see Mr. O'Brien wants to come in, so I might let him come in the first instance.
Just to let Deputy Lahart know that the HSC's latest dashboard, so about 250 people have had a second AstraZeneca vaccine, so that had just started.
Thank you very much. Okay, thank you.
So to your question then, Deputy, whilst I appreciate that there will be people with concerns and very legitimate concerns, and I think those concerns need to be addressed at an individual level, I don't think we're in a position to offer choice, given that we absolutely stand over the safety and effectiveness of this vaccine for the people for whom it will be offered. As you may have heard last night, the chances of someone aged 60 or older dying as a result of contracting COVID is 85 times higher than the risk of any clotting event arising out of receipt of the Astrozenica vaccine. So I understand that there will be concerns, and I'm very sympathetic both to those concerns, and I'm sympathetic to politicians and indeed general practitioners all across the country today who I have no doubt are fielding questions and having to deal with concerns. I think those are concerns that we need to address and resolve, as opposed to going down an alternative route. This vaccine is safe and effective as the other vaccines in the age group for whom it's been recommended. And in fact, the approach taken by ourselves and by NIAC is a very conservative approach, and you could argue, in fact, that it could have been recommended at a lower age cutoff, but out of, as we said last night, an abundance of caution, the 60-year cutoff was chosen, and that's in line with Germany, Italy, the Netherlands, Spain, and a number of other European.
Okay, and look, can I just say that this abundance of caution is probably something we're learning about this just as you are. It's probably something you're going to have to exercise, perhaps potentially with another vaccine or two as they come along. So there's a piece of very significant work here to be done. It's not about reassuring people. I think the clear message you've said to me today seems to imply that a GP could address that on a one-to-one basis with a patient. Is that one of the avenues that you're suggesting?
Well, in the first instance, we need to ensure that the GPs have all of the information that they need in order to address those concerns. But yes, ultimately we know that the consultation between a general practitioner and a patient is the single most effective way of addressing concerns around vaccines and ensuring that people have those concerns addressed and are willing to take the vaccine when it's offered.
But you're ruling out a choice.
Yes, I think so. On the basis of the evidence that we have in front of us, there isn't an indication for that, accepting that there will be people who have concerns that need to be addressed.
Okay,
Thanks,
John.
doctors.
Thank you. Again, just to inform the general public who are probably watching this at home, we're having technical issues again with the cameras. So again, witnesses and members, I apologise. So I'm going to move on to Roisin in Chartha.
Thanks, Chair, and I'd like to welcome you, Dr. Glynn, and your colleagues, and thank you for your ongoing work. Dr. Glynn, earlier you said that we have to do all we can to prevent the introduction of new variants, and I think we'd all agree with that. And in that context, I just want to raise with you some questions about the decisions around mandatory hotel quarantining and the rationale for the selection of those countries that are included on the risks and, on the lists, and if you just provide us with some of the science underpinning those decisions, please. Yesterday morning, the Minister for Health said on radio that the main criteria for selecting EU countries for mandatory quarantining is the level of variance. And I think just questions arise about that. And my first question is, why is there a distinction between the selection of European countries and the rest of the world in terms of the criteria that would apply? My second question in that regard is in relation to a dependence on the selection of countries, the criteria of the level of new variants. Sorry, can you hear me?
Yes, sorry.
Yeah.
In the context of several EU countries that don't actually engage in genomic sequencing, or where that science is very weak, and we know from an ECDC report back in February that several European countries don't carry out genomic sequencing. What's your view on the accuracy then, or the implications of the fact that many EU countries can't be relied upon in terms of providing data on genomic sequencing? And is it a case then that those countries are rewarded by not being included in relation to mandatory hotel quarantining? And my third question then relates to the incidence and how it is that the incidence of the virus seems to be set aside when it comes to selecting countries at EU level. Because when we look at the figures, you know, say Italy, Belgium, Austria, countries that are now on the list, they're kind of around 500 a rate. They have a rate of around 500 per 100,000 on the 14-day incidence. Whereas you look at other countries that aren't on the list, and they're in the region of 1,000 cases per 100,000. So what exactly is the science underpinning the selection of those countries? Thank you.
Thank you, Deputy. So the advice that we provide is based on either known knowledge about variants of concern in a particular state, or in relation to high incidence. We don't differentiate between the EU and the rest of the world. We feel that given the challenge...
Was that statement by the Minister then not exactly accurate? If he said the main criteria at EU level is the new variants?
So recognising, I suppose, that there may well be constraints in the establishment and the setting up and the expansion of this system, in the advice that we provide, we do advise that in the first instance the focus should be on countries with known variants of concern, followed by countries or states with very high incidence, more than 500 per 100,000, followed by states with high incidence, which is less than 500 per 100,000, but more than 2.5 times Ireland's 14-day incidence.
Okay, but again, just in terms of the science underpinning this, if you have no knowledge of the new variants in certain EU countries, I mean, why would you not include them then as a precautionary approach?
So to be clear, when we look at this, we do not differentiate between the EU and the rest of the world. We look at countries with variants of concern, then countries or states with a very high incidence, and countries or states with an incidence more than 2.5 times Ireland's incidence. We fully recognise that given that many countries have a challenge in either carrying out or for whatever reason reporting data on variants of concern, it is our belief that it is appropriate to examine overall disease incidence in countries, because we know that incidence is associated with the emergence and spread of variants of concerns. We know that the ECDC has previously been clear on the potential threat posed by variants and the likely further spread of those variants both within the EU and internationally. And it's in all of that context that we provide advice which looks at both variants and incidence.
Okay, so just to confirm, it's a combination of those three criteria that you set down that are applied equally to all countries. Is that the case?
So we apply them equally to all countries, and then we advise that if there are constraints, that in order of priority, there needs to be a focus in the first instance on countries with known variants or probable variants, followed by very high incidence, followed by high incidence.
Okay, is that data...
Less than a minute left.
Is that data available publicly?
Certainly in relation to the incidence data is available publicly. The ECDC published data on a weekly basis.
For Ireland, I'm saying, the base for the selection of countries in Ireland. Is that data available to us?
Yeah, well, basically, if you take Ireland's, so when the Expert Advisory Travel Group meet on a given date, they look at Ireland's 14-day incidence, and then everyone over 500 is advised to be included, regardless of Ireland's position. And then if a country is less than 500 but more than 2.5 times Ireland's current 14-day incidence, the advice to date has been that they would also be considered for inclusion.
Okay, could I ask you one last question, just very briefly? Where a case of, for example, P1 is identified, what is the work then done on that? Is that done centrally by public health doctors, or is it dependent on the strength of the regional public health teams?
So it would be a combination, Deputy Shorthall, but the regional public health teams would have a significant role to play, along with, in particular, the contact tracing centre at UCD has a central role in the management of these cases, and of course the public health doctors working at national level. And as I said, last week we received updated protocols and guidance in relation to the management of those variants, and that guidance was endorsed, and I'm sure the HC can update on that next week, or we can certainly provide a note on the approach being taken if that's more appropriate.
Okay, I'd appreciate that, Dr. Glynn. Thank you.
Nessa Horrigan.
Thank you, Chair, and good afternoon, and thank you to everyone who's here today. I don't want to spend too much time on AstraZeneca because I think it's been covered by other deputies and yourselves quite well, but before I start my other questions, I'm aware that in some European countries, if you're halfway through the process, I guess, if you've taken the first dose, they've decided not to continue with the second dose and start with a new vaccine. Is that going to be the case here?
So at present, Deputy, the plan is that if you're in a high risk, if you're someone who's at high risk or very high risk of a severe outcome from COVID, where you contract COVID, and you've received your first dose, you should receive your second dose as planned after 12 weeks, because the benefits of receiving that vaccine to protect you outweigh any potential risks.
Is that the same in every age cohort?
So that is the same across all age cohorts. Equally, all people over the age of 60 or 60 or older who've received a first dose should receive their second dose as planned after 12 weeks. All people aged less than 60 who aren't at high risk or very high risk who've received a first dose, their second dose should be deferred until 16 weeks after the first dose. Those people then won't be due to get their second dose for about another 5 or 6 weeks. That gives NIAC further time to consider whether there's an alternative strategy that might now be more appropriate, whether that involves, for example, giving a different type of vaccine as a second dose. I suppose it is just important to point out that in the UK, 800,000 second doses of AstraZeneca have been given to date with no negative outcomes. So it may be that this issue that's been identified is something that shows itself after a first dose as opposed to after a second dose. But as I say, the next few weeks will allow us to further assess that and come back with updated recommendations.
Okay, absolutely. That seems to make sense. Do you have any sense of how many people would be in that last cohort we're talking about, out of the 200 or so thousand doses that have been given?
I don't, but we can certainly get you a note on that.
Okay.
I don't have a breakdown of that.
A number of deputies have asked about the reopening and the pathway out of this, and we've talked a little bit about businesses and sport. One of the areas that I received the most correspondence around is maternal care and access to services during pregnancy and birth and labour. And I'm aware that obviously hospitals are kind of a nucleus of activity when we're talking about a pandemic. So I'm not asking for a date or anything, but in terms of a rollout, when we see things reopening, at what stage do you expect to see access, more free and available access to kind of hospital services and the reopening of those kind of services as part of the general opening up?
So, sorry, I missed the very start. Are you talking about, for example, access to maternity for partners and...
Exactly right. That I had somebody just yesterday telling me that they've given birth and are in the hospital on their own for the day, and would have liked to have their partner there and simply are not able to do that. So when will we see that in the rollout? Not necessarily a date, but in the kind of framework of the rollout, when will that particular service be more available to people?
So this won't be the answer that you want, and I know it won't be satisfactory, but that's actually not something that we have ever given any specific advice on. That the approach taken is based on advice and guidance within the HSE, and so it has always been the HSE that has determined that position. So they may well be able to update next week, but ultimately it will come down to the level of disease in the community, which hopefully will continue to improve over the coming weeks.
Okay. In your opening statement, one of the lines was that they were looking at pilot studies being conducted around antigen testing. That's something that's actually come up in front of the committee before as it relates to nursing homes. I'm wondering, could you expand on that, on those pilot studies and how they're going?
Sure. So These are pilot studies that are being established or set up by colleagues in the HSE. As you may be aware, that they've already validated and used these tests in some acute hospital settings. As you may also be aware, in relation to your question, nursing homes, we eased or updated our recommendations around visitation a few weeks ago, and we'll be coming back to that issue shortly at NEFIT. And I suppose just one data point maybe that gives people more hope and gives people more. It shows again the impact of these vaccines. Last week we had no outbreaks reported in nursing homes, no new outbreaks reported in nursing homes across the country, and that's the first time that that's happened since last July. So that's a really welcome development, and again shows the impact that vaccination can have. In relation to nursing homes, we are looking at the issue of visitation and the issue of serial testing and the ongoing role of serial testing. As I say, we'll be looking at that in more detail over this week and next week. In relation to antigen testing, the HSE is looking at the potential for its deployment and use as an additional tool in childcare settings across the various components of the education sector and higher education, working with colleagues in the Department of Education, Department of Higher Education. It has also been deployed to some extent in the meat processing industry, and an evaluation of that is happening as we speak to look at the value or otherwise, the utility or otherwise of it versus cost and other considerations. It's been rolled out over the past month.
Okay.
And then obviously subject to the recent Ferguson report, I know that the Department of Enterprise and a whole range of other government departments are looking at the potential for adding antigen testing as one more layer in their approach.
I might try and get one. I've only 1 minute left, so just one very quick question before I go. But I would like to say that no new cases in nursing homes is certainly a massive good news story.
Sorry, Deputy, just to be clear, because I know it'll get misreported. No new outbreaks in nursing homes.
No new outbreaks. Fair enough. In your opening statement, you also say that we need an adequate amount of time between phases of reopening to assess the impact of that reopening. Could you give us a sense of what that adequate amount? So every time there's a new phase in the reopening, is it 14 days? Is it 20 days? What would you consider adequate time to assess?
So we've always been clear that really you need a minimum of 3 weeks to fully understand the impact of a significant change in measures. So of course, as we're seeing at the moment, there was a set of measures 2 weeks ago, on Monday, and there'll be further things happening this month. But prior to another substantial set, you would want at least 3 weeks to fully understand if there's been a negative impact.
Thanks.
Thank you. Gino Kenny? You're on mute, I think, Gino. You're not. The camera's not working either. So you're still on. Yeah, now.
Okay, can't see me. Okay. Thanks, Chair, and thanks, Dr. Glynn and his team in regards to today's statement. I think today's statement gives a lot of people hope in relation to the public health emergency that we're all living in, and it also kind of notes of a word of caution. I think that's welcome as well, because we're living in kind of, I suppose, times that things can go wrong. I just wanted to ask Dr. Glynn in relation to his note of caution and his note of hope, particularly in the next 6 weeks. That's a vital phase of the pandemic and how it's and the vaccine rollout. But what weaknesses does he potentially see in the next 6 weeks that could undermine the good work that what's happened in the particularly last 3 months?
I don't know that there's weaknesses per se. I mean, I have uncertainties, I suppose, are the way I'd characterise it. So there are uncertainties around the potential of emergence of a variant. If we had a super spreading event or a small number of super spreading events of a variant of concern, that could alter the picture here. If we have further issues with vaccine rollout, or if the planned rollout of vaccine to 80% of the population to have a first dose by the end of June, I think they're the key elements. I remain, and I've always remained, despite I'm sure no one believes it, but actually I've always been optimistic about the public's willingness to buy into measures despite the fatigue, and they've continued. Like the fact that we have not seen an increase in close contacts per case since the middle of February is simply phenomenal. It really shows that despite, obviously well publicised incidences where a small number of people are not complying, the vast majority of people are continuing to try to do the right thing. And so that, more than anything else, makes me hopeful that we will continue along an appropriate trajectory over the coming weeks, and that we will get to where we need to by June and into July.
Okay. My second question is in relation to the Astrozeneca vaccine and the recommendations by NIAC. What do you think the consequences of the overall vaccine rollout has, the interruption, in relation to the recommendations of NIAC has, what it has done? What's the unintended consequences, and what's the consequences, particularly for, as I said, the vaccine rollout?
So I think we'll need to wait to see precisely how the HSE reallocates the vaccine to various cohorts and how it plans to deploy available vaccines. But what I would say is AstraZeneca only accounts for 20% roughly of vaccines over the next kind of 8 weeks. There are a significant number of people who have not been vaccinated who are eligible and will be eligible for AstraZeneca. And indeed, we will have a significant number of people who require a second dose with AstraZeneca. So all of those people getting AstraZeneca will mean that there are that Pfizer and Moderna and hopefully the Johnson & Johnson vaccine are available for other groups of people. So I would hope, on the basis of last night's recommendations, that the impact on the overall rollout at a population level should be fairly minimal. When you look forward to where we'll be now, I mean by the end of May, the end of June, as opposed to, obviously there's an interruption this week and over the coming days, but hopefully that can be addressed pretty quickly.
Yeah, and it was reported in some media outlets that because of the recommendation by NIAC in relation to AstraZeneca, that cohort of 60 to 69 age group will probably get a bit of a boost in regards to vaccine supply. So is that's possible over the next, say, 6 weeks, particularly like the next?
Yeah, I mean, I think obviously the AstraZeneca that would have been going to other groups will now be available, and clearly those aged 60 and older. So it's not just 60 to 69. To be clear, AstraZeneca can be used for anybody aged 60 and older. So clearly there will be substantial supply of vaccine, AstraZeneca vaccine, that will now be available for people in that cohort. And I would expect, obviously subject to hearing from the HSE, but I would expect that people who would otherwise have been waiting a little bit longer to get vaccine will likely now be offered AstraZeneca.
My next question is in relation to vaccinators. Obviously the period that we're in at the moment, there's going to be a ramping up of supply of vaccines. Are you confident that we have enough vaccinators to kind of meet the demand to vaccinate people in the state? There has been problems with kind of the criteria of vaccinators getting in the position where they can vaccinate. But will there be an issue of a choke point where there's a supply of vaccines but don't have enough vaccinators? So are you confident that we can meet that demand through the 11,000 people that you would need plus to vaccinate the population over the next 6 months?
I might ask Mr. O'Brien to come in on that question, if that's okay, Deputy.
Yeah, Deputy, we've been engaging with the HSE regarding the recruitment of vaccinators. So certainly we have, and the high-level task force on vaccines have comfort around vaccinations through April and May, and there's ongoing recruitment to ensure the vaccination workforce is in place thereafter. It's not just vaccinators, we have GPs and then at some stage pharmacists and others coming on board. So it's a very broad ranging offering of who can vaccinate. But in terms of the mass vaccination clinics and the population who will vaccinate there, we certainly, the HSC are doing everything they can to recruit people, and certainly for April and May, we have confidence that the numbers are there already to do that.
Okay, is that okay, Gino?
Yeah, just a very, very quick question in relation to vaccine hesitancy. This could become a bigger issue than we wanted, you know, and the one thing we do not want is vaccine hesitancy become a kind of a bigger issue than it is. And but is there any kind of plans to clarify, particularly around advertisements, around kind of vaccine hesitancy in relation to the vaccines that are kind of, going to be kind of available for supply over the next 3 to 6 months?
So just, I suppose the short answer is yes, the HSC is doing very specific work in this regard, in particular around possibly harder to reach groups or groups that may require information in different ways, different languages. And I think from our perspective as well, as I said at the press conference last night, we need to kind of step it up. But as a society, I think we need to move away from a focus, and I fully appreciate and understand the focus on numbers, and we need to keep that focus. But in tandem with that, increasingly we need to focus on other issues around vaccines, why people want to get vaccines, why people don't want to get vaccines, what their concerns are, and address them across a range of fora. And so, again, if people have suggestions for ways in which we need to communicate differently or better in relation to vaccines, happy to take any of that on board and try to get messages out through different fora.
Thank you.
Thank you, Gino. Colin Burke.
Yeah, thank you very much, and thank you for your presentation. Can I go back on the AstraZeneca issue? And I know a lot of people have raised it, and it's about getting information out there now. We're now talking about over 60s. The focus is going to be in relation to AstraZeneca, but we have a huge problem now in that they're not convinced. And I'm just wondering if a lot more can be done about getting information out there to show why this decision has been arrived at. Because it's what has been put out there so far, like the details of the research, etc. I don't think is out there. Well, sorry, it may be available, but it's not out there in a broad sense. And I'm just wondering if a lot more could be done on that, and if there are plans, are you aware of any plans by the HSE to do to get information out there to the public on the issue?
So. Obviously, the communication effort started last night. That communication effort needs to continue. The NIAC advice is up on the RCPI website, to the best of my knowledge already. But again, it comes back, I suppose, to an earlier point, which is that what we really need to do here is equip our healthcare professionals in the community to address the concerns as individual people raise those questions with them. And over the coming days, we will step up our communication efforts to try and answer specific questions around and concerns around the vaccine.
Okay. Can I just move on to another issue, and that's, and I know that one or two deputies have already raised this, and this is about the use of antigen, and in particular in relation to safe parents attending maternity wards, and this issue was raised. Why hasn't that? We're now talking about doing a pilot project on this. But isn't there enough research done already showing, okay, we fully accept it's not comprehensive, it's not conclusive, but why do we need to do a pilot test when all of the information in relation to use of the antigen test is already there? And why can't we use it, for instance, in relation to maternity services? The other one that's a big issue now at the moment, in that most of the people over 80 have been vaccinated, there's a need to open up day centres where they used to normally attend, because remember, they've been locked up for more than 12 months now. They want to get out. Can that not also be used in relation to trying to open up those centres and bring it, rather than delaying it for another 6 months? And I'm just wondering if that will be considered at this stage.
So your second point, I think, is a question for the HSE directly in relation to antigen testing. And I suppose you raise an interesting point in your question, which is the evidence not there? There's a real debate going on across the medical and scientific community in relation to the value or otherwise of antigen. just because we all want something to be really effective and to make an enormous difference does not mean that it will. And some of the portrayal of antigen testing internationally, in that it would prevent lockdowns, it would be the panacea. There simply isn't evidence in the medical or scientific literature to support that. And our public health colleagues, our pathology colleagues in the HSE who deal with these issues on a daily basis don't support that view. However, there is a role for antigen testing in particular settings as an additional layer, but ultimately that has to be driven by our clinical colleagues in the HSE, where they see a value in the role of antigen. Wherever, and to be very clear, wherever antigen testing can play an additional role and bring additional value over and above our current public health response, it should be facilitated, it should be trialled, it should be used. But I would also, I suppose, reiterate that we have been looking very closely at the evidence around antigen testing since last August. So it's not that the issue was ignored or sidelined. The issue was looked at actively, and the reality is that even as of certainly up to a couple of weeks ago, there was no test validated for use in asymptomatic people.
Can I just ask one question in relation to the quarantine that's there in relation to people who are flying in from abroad? In the US now, they're allowing people to come in from abroad, provided they can show that they've had vaccination, they have the required vaccination. And the question then is, why can't we apply the same rule here? For instance, one of the issues that could be introduced is antibody testing, whereby when a person comes in, there is a test that can be done to see that people have the antibodies. And I'm just wondering, can that be visited rather than going down through the road of quarantine, where people have clear evidence that they've gone through the entire process in relation to vaccination?
So clearly we all want vaccination to make a significant difference to our ability to travel. I suppose the position at the moment is that a very small proportion of our population is fully protected. A very small proportion of populations internationally are fully protected at present. Even where they are fully protected, we still don't have sufficient information on the issue of transmission. Even where they are fully protected from the variant that we have here at present, we don't yet have enough information. And indeed, we're seeing increasing incidences of breakthrough infection with other variants in people who've been vaccinated internationally. Furthermore, there's the issue of whether or not we could have a system which properly authenticates vaccine certificates. And none of this is insurmountable. None of this is forever. The epidemiological situation across the EU, for example, is improving as we speak. The EU, as we speak, is looking at an EU-wide system of vaccination certification. So I think we're all going in the right direction, but it will take weeks to get there.
In America, they've now decided to go down this route, which is a far bigger jurisdiction, and they're prepared to take that risk. They're satisfied that they can go down this route, and they have bigger numbers to deal with.
Colin, we've run out of time.
They are satisfied to go down that route, but I guess that's a matter for those authorities, and their epidemiological situation is different to ours at present and is going in the wrong direction, but that is a matter for those authorities.
Okay, next question here is Senator Annie Howie.
Hi, thanks everyone. Hopefully this sounds all right here. If it would be all right, I just very quickly want to follow up from a point that came up during Deputy Horgan's questions, and it's veering a little bit off course, but can I ask why NPHET make recommendations for things like nursing homes, but not recommendations on things like maternity services? I know that there's reasoning that not all maternity services and wards have spacing and capacity, but I'd hazard that probably no two nursing homes are of the same size or layout. But NPHET do make recommendations in terms of when people can come in and out. I'm just wondering, is there a differentiation that I just don't know about, or why do you not make recommendations in relation to maternity, but maybe for nursing homes and stuff?
I suppose there isn't an entirely straightforward answer to that. Some of it is historical in the areas of focus that there would have been at a particular time. I suppose the issue with nursing homes is that they are across sectors and across society, and it's not necessarily all HSE, for example. So that would play in as well. But ultimately what happens, we would assume in large part that what happens in within the HSE is a matter for the HSE. Obviously, if there's a need for a wider policy discussion about that, that can happen at NEPIT, but to date, the issue of maternity services has been a matter that's been dealt with by the HSE.
Okay, cool. I'm just interested in that. I wonder if I could ask for your thoughts on, I suppose, how taking or refusing the jab will or maybe could affect employment and access to services. So again, it's you know, NPHET, you know, you make far-reaching recommendations on lots of things that affect society's health and the economy. And is there any plans, or have you thought about this in terms of what your recommendation will be as part of the ongoing sort of opening rollout for those who, for whatever reasons, cannot or will not get the jab? So I know you said that you need about 80% of the adult population with at least one dose of the vaccine by June, I think you said, in order to reasonably get things moving. But how are places, or have you thoughts on what recommendations you're going to make to manage things when there are cohorts of people who cannot or will not get the vaccine? I'm not necessarily going as far as into, you know, discussions around vaccine passports and stuff like that, but, you know, it is a genuine question about, well, what are the recommendations for what people should do, what businesses should do, what government should recommend?
So I think there's a few elements to that, Senator. So that's kind of an ongoing conversation at the moment. So, for example, we would have considered at NEPIT last week the issue of the approach to healthcare workers who decide not to get vaccinated. From a personal perspective, I think that we need to really focus over the next few months on conversations, one-to-one conversations, on ensuring people have the information so that their concerns are addressed. Across vaccination programs and across countries, generally speaking, you're talking about 5% at most of a population, of an adult population, who will be resolutely anti-vaccine. They won't change their mind, and no matter what measures we bring in or don't bring in, they have already decided that they will not take one of these vaccines. What we need to do is to address the concerns of the proportion of people who have legitimate questions. I think at this point I would be very hesitant personally to suggest that we'd be going down a route of differentiating at a societal level between people who've been vaccinated or not vaccinated. And I would hope that the vast majority of people will see that the vaccine offers protection for themselves and their families, and will choose to take that vaccine when it's offered to them. Obviously, it's something we'll have to continue to monitor, but I think for now our focus needs to be on ensuring that we can maintain the very high levels of vaccine confidence that we have in the country at present.
Okay, thank you. And I'm just going to ask one last question. I'm thinking about the long-term rollout of the vaccine, and I know we're only on the initial rollout of the first rounds of it, so it might be a little bit premature for me to be thinking about later phases. But how do you foresee, like, long-term planning of managing the virus and vaccines working out? You know, is there potential for this vaccine to become like the flu vaccine, where large swathes of the population will have to get the vaccine regularly? And if you think that's a possibility that's going to happen, how would you see that vaccine rollout being managed? Would it go into pharmacies the way the flu vaccine currently is, or do you foresee it, if we have to do it again, remaining in the current situation with GPs and health settings?
So whether or not it becomes an annual necessity, I suppose, is an open question at the moment. I think it is more likely, at least at this stage, that we may need to see a booster programme next autumn or winter, although that's not entirely clear either at this point. To your specific question about how it would be deployed, I think that largely depends on developments with vaccines over the coming weeks and months, and whether or not we're still using all the vaccines that we currently have, whether better and different vaccines come along, and what the requirements of those would be in terms of deployment and administration. But I suppose if we need to run a similar programme, for example, next autumn, where we need to offer vaccine to everyone aged 16 years and older in the population, I think we would again have to be using every avenue available to ensure that uptake is as high as it can be.
Okay, thanks so much. That's me done.
Thank you very much, Annie. Cathal Crowe.
Thank you, Chairman. My audio is working, is it?
Yeah.
Yes.
Okay, I just want to confirm at the outset I'm here in Leinster House. Thank you, Dr. Glynn, for joining us here today. There's a number of questions I'd like to go through. Like others, I planned on asking a few bits about AstraZeneca, but it's been well covered, and thank you for answering the questions thus far. Just at the outset, something that I have been delving into over the last number of weeks is the European Centre for Disease Control and Prevention. And I'd like to probe a little bit on that and how much engagement you would have with them and NPHET would have with them on a week-to-week basis, because I was rather alarmed to discover that they're based in Stockholm. They only employ 300 people. Their annual operational budget is 50 million. Compared to the United States, where their equivalent coordinating health body has an annual budget of 12 billion. So have you had many interactions with them weekly? Do you find any deficiencies in what they're able to supply you with in information terms in a coordinating capacity across the European Union bloc, please?
So we would have very regular engagement with the ECDC, both at departmental level, but also through colleagues in the HSC who would engage in terms of data sharing and on a very regular basis. And we would have people who would sit on the advisory forum and management board forum for the ECDC. I think there has been a recognition at European level that the response overall wasn't as optimum as it could have been. And that we need to reflect on that and ensure that we're better prepared in the future. And from that perspective, the EU is already taking a new, I won't call it an agency at this stage because it's not entirely clear what form, but a health emergency preparedness and response authority. So there's work ongoing at that, and I would expect to have more detail on that probably by the end of the summer. Okay. But the ECDC has played an important role in our understanding, particularly around disease transmission. But of course, we don't rely alone on the ECDC. We have very regular engagement with colleagues in Northern Ireland, with colleagues across the UK, and we would also be keeping abreast of developments at WHO level and ECDC.
Okay. Thank you, Dr. Glynn. It must be calamitous to think that on a daily basis, you've all these other member states phoning in about vaccinations and looking for advice and figures and statistics, and only 300 staff dealing with that. And to think that European-wide, more was spent last year on a space exploration programme than on coordinating the European-wide effort. And they're an 18-year-old entity, considering that yourselves and NPHET were only set up on the 27th of January last year. You've done a hell of a lot of good work in that time, but it just seems unforgivable that an entity set up at the very first SARS outbreak in 2002 or 3, I believe, that they are the same entity years later that I think in this occasion have proven unfit for purpose. Could I move on, Dr. Glynn? The Taoiseach this morning was speaking at the Hospitality and Tourism Expo, and he was questioned by the media with regard to reopening of various sectors, and he hinted that, well, quite clearly he hinted that there will be hopefully a reopening of bed and breakfasts, guest houses, hotels in the June period. I suppose everyone is wondering what's NPHET's view now on bars and restaurants, and maybe when you answer, you might also tell us the logic that NPHET would have in just differentiating between a food serving gastropub versus a wet pub. Okay, I understand what they're serving is rather different, but in a health context, how are they different? Because I think that's a question repeatedly we're asked, and it's a question repeatedly we probably don't have a good answer on. Thank you, Dr. Glynn.
Thank you. This answer definitely won't be satisfactory, I think, but at the end of this month, we would hope to look again at the data, see how we've gone through April and set out a plan for May, June and July. And as part of that, we will be giving consideration to the whole area of hospitality. In relation to this issue of pubs versus gastropubs, to be clear, NPHET never said one word about a €9 meal. But we do have a concern about alcohol in the context of a global pandemic. And like, again, I know I'll be painted in the wrong way because of this, but like, you can't get away from the fact that when we have a drink, when we have a few drinks, we let our guard down, we drop our guard, we're less likely to social distance, we're less likely to ensure that we're following all the measures that we should be following. Many of these establishments are poorly ventilated. It involves mixing of multiple households, and whether we like it or not, we saw the effect of that at various times last summer. We saw the effect of that over the Christmas period, and unfortunately it's not a message anybody wants to hear, but these in relative terms are high risk environments, and we have to put that in context when we're weighing up the risk of further waves, further outbreaks, the risk of super spreading events, all of that versus the need to keep our children in school, the need to get our hospital services up and running, and the need to protect the most vulnerable until they're vaccinated. So it's not an easy message. I understand that.
Okay.
We all want to go to the pub, but we're not there yet.
I appreciate that. They have to be part of the roadmap going forward, though, I would suggest, when your next round of considerations are made. I've only 1 minute left, so I just want to ask maybe a few quick-fire questions. The digital green certificate, I see it has been hugely positive. It's a pathway back for a safe resumption of international air travel. Do you think Irish people, beyond a trip to the coastline or to the beach this summer with a bucket and spade, can they realistically look forward, with the digital green cert coming into, having a holiday abroad this summer? And very finally, you might just answer this when you wrap up. You were established, as I said, on the 27th of January 2020, and this is just a question. I want to thank you for what you're doing. Do you envisage a continued role for an effort yourself, Tony Hoole, and all of your team, beyond this immediate period, the autumn and the winter, because you're continuously telling us COVID could be around for 5 or 10 years perhaps? Do you consider there will be a need for an advisory body there, on the shoulder of government, on the shoulder of health services for all of that period? Thank you.
I certainly hope that we will be able to move relatively shortly away from the spotlight that we have that we don't want. We have a public health role to play. I would hope that as vaccination rolls out, if we can keep incidence low, that our role will become less and less visible, less and less important, and less on the front pages of the newspapers. That's not where we want to be, contrary to some public opinion on that. It's not what we enjoy, and it's not where we want to be. So I would hope that if we can get the majority of the adult population vaccinated, and if disease levels are still low at that point, that you'll see a step change in the NEPID response. Like, we need to move away from what has essentially been an emergency response to integrating
and do you think we'll get foreign holidays, non-essential air travel back? What's your opinion on that over the summer period, as the vaccination situation improves?
I think there's too much uncertainty around the European situation at present to give anyone any measure of certainty in relation to travel at this point. I'd encourage people, I hope that we'll have a very open and very good summer in this country, and I'd hope that for this year that the focus would be on the hospitality sector and on travel within this country, keeping us all safe and keeping the disease under control.
Okay. Thanks, Dr. Glynn. Thank you, Chairman.
Thank you. So you want to be more shy in retiring, Ron?
Definitely.
Okay. Senator Francis Black.
Thank you very much, Cathaoirleach. And firstly, I want to say thank you to yourself, Dr. Glynn, and your team for the phenomenal work that you're doing. And I, for one, really appreciate it. I mean, who would have thought, certainly not in my lifetime, and I'm a long time on this earth, did I ever think I'd see a pandemic like this? This is all new to everybody, and I know, and I just think you're doing a great job, and I thank you for that. I don't have a huge amount to say. I suppose the concerns that I would have are around, long term, the impact of mental health and the tsunami that's going to come down the road. I mean, there isn't a person on this island who hasn't been impacted in some way. An awful lot of people are struggling with loneliness. We can look at the health workers, the frontline staff and the impact on all of them. So I do think we are, on for a very tsunami of mental health issues. But the question I have for you really, and I know a lot of it has been covered today, but I suppose the concern, a lot of people are concerned about the possibility of the rare blood clotting disorder associated with the Astrozenica vaccine. And, we know, it's been spoken about today, this could lead to people refusing the vaccine. So, and I think I recently heard that the Taoiseach said at one point that this can be treatable, that the blood clotting disorder is treatable. And I just wanted to check with you if you know that if this is true, and because I really believe that people their minds would be put at rest if they knew that this blood clotting disorder, that it's not fatal. And I think that's where, if that's true, that it is treatable and it's not fatal, then I think that's where we should really look at the media, and because you're hearing it all the time, you're hearing this on the media all the time, Astrozenica is going to cause blood clots, but if we could hear that it's going to be okay, that it's treatable, that people aren't going to die, and that it's more important to deal with the actual COVID pandemic than to deal with the blood clotting. So I'm just wondering what your thoughts are on that and what you think.
Sure, thanks, Senator. So we know that, there's still significant uncertainty around the extent to which this is an issue. And from NIAC's perspective, they went conservative and looked at, they took all events to date and assumed that they were all these very serious clotting events, when in fact we don't know that to be the case just yet, because some of them remain under investigation. But we know that somewhere between 4 and 10 of these events will happen for every 1 million people who are vaccinated. And to date, we've only been reporting, or the EMA has only been notified of approximately 1 fatality per 1 million people vaccinated. So the majority of people, at least notified to date, with these conditions have survived. It is a serious condition, but the majority of people, as I say, have survived. And I come back to my earlier point, which I suppose is that the risk of someone in their 60s dying from COVID is 85% higher than their risk of suffering one of these clotting events. And in the event they do suffer one of these clotting events, as I say, it's not a given that will be a fatal event. So the balance is firmly in terms of getting the vaccine for anyone who's offered it.
Okay, thank you. And then just finally, I just have one other question, and it may not be irrelevant, I'm not sure, but we know that the North is ahead of us with vaccinations being rolled out for people. I think they're on people who are now in their 40s. Just wondering, do you have any concerns about the North opening up before the South? What your thinking is on that? Would people be travelling up to the North, maybe going to a few pubs? Or I just wondering what your thinking is, and would it be something that you might be concerned about?
So I've no doubt that if there's opportunities to do things in Northern Ireland that aren't available here, that there will be a minority of people who avail of those opportunities. But equally, I think whilst the North is ahead of us, they are moving in a conservative manner as well. We're not that far behind in terms of our measures. I know every week feels like an eternity to people in terms of what's in place, but in overall terms, we're not that far behind. If our vaccination programme rolls out as it should over the coming weeks, we'll catch up in terms of the level of protection. And as I say, if we can avoid an increase in incidence over the coming weeks, I think we'll be in a position very similar, so that again we'll have an all-island epidemiological unit as opposed to 2 jurisdictions.
Fantastic. Thank you very much.
Thank you.
Thank you, Chair.
Thank you. Senator Martin Conway.
Margaret, thank you, Chairperson, and I would also like to add my sincere thanks to Dr. Glenn and Professor Nolan and their backup and support teams for the great work they've done over the last 12 months plus at this stage. A couple of concerns and questions, and a lot of what I would have asked has been asked, so I don't intend to go over that ground. But there is a concern now regarding nursing homes, in the sense that, residents in nursing homes in January primarily received their first dose, and a short period after that got their second dose and are, to a large extent, fully vaccinated. But the concern is what happens in 6 months, because we don't really know, at least certainly the public doesn't really know what the immune length of time is, and have effort given any consideration to the post 6 month period, particularly as regards nursing homes. And second question then, and maybe observations from yourselves, From a NIPT perspective and a public health perspective, I'm quite concerned, and maybe it's unfounded, but you might tell me. We're seeing vaccination centres for vulnerable people and vulnerable people being vaccinated in Dublin, for example, and that's a good thing. And anyone who's vaccinated is very welcome. But when you see people travelling from Donegal, for example, who are vulnerable people, to get vaccinated in Dublin, it doesn't make sense to me. You're talking about a 4-hour journey in both directions, and most likely those vulnerable people will have to be transported. Surely there's a risk and a concern there. So there are my first two questions. I have one supplementary afterwards then. Thank you.
Okay, just to your first question on I suppose the duration of immunity is an open question at the moment. At present, our position is that people can reasonably expect to be protected for a period of up to 6 months after being fully vaccinated. In fact, I'd be hopeful that the duration of protection will extend far beyond that. It's just simply that we haven't had enough time to collect that data because people haven't been vaccinated for long enough yet. But the evidence is promising, and this is something that we are monitoring on a kind of monthly to 6-weekly basis. But as I say, I would anticipate that the duration, that we will be saying further positive things about the duration of immunity in the weeks to come.
Good news.
I suppose that the one caveat to that is the issue of variance. And whilst we have reasonable confidence around the duration of immunity with regard to the B117 with vaccination, we're not as confident in relation to the South African variant. In relation to the question on where people have to travel to, I would hope that as so far as is possible, people are getting vaccinated close to their home. But I also recognise that may not be possible in every scenario for a variety of reasons. But I can't speak to the detail of that, unfortunately.
Would you share my concern if people are travelling across the country to get vaccinated?
Well, I would if they're stopping off along the way and interacting with people along the way. But regardless of that risk, I suppose in keeping with the general principle that we want people to be treated generally as close to home as possible, I think that would also apply here, accepting that there may be particular reasons why people have had to travel. I don't know the detail.
Yeah, and it's a lot more common than you would think. Just one final question. Clearly, hospitality is going to open, outside dining perhaps, over the summer, something similar perhaps to last year. Obviously, there's going to be protocols and recommendations and so on. This is work I would suspect that NPHET should be working on at this point in time, because whether it is opening up in May or opening up in June for outside dining, it's going to happen at some stage in the coming months, we all hope. And I'm sure with the evolution of the virus that we're looking at new recommendations, whether it be 1 foot apart, 2 foot apart, X number of people at tables and that. Is there preparatory work being done on that? Because to be fair to the hospitality industry, they should get some prior notice, and also government should get some prior notice as well, because they're going to have to obviously put financial supports in place to accommodate such recommendations and changes.
So I suppose the first thing to say on that is that many of the protocols and protective measures that need to be in place were in place previously, so they'll just need to be recommenced. But I absolutely, and I think the point is made earlier as well, is that various sectors need time to anticipate that they'll be reopening in whatever form that will be. So again, hopefully at the end of this month, if the disease remains stable or indeed improves over the coming weeks, then we hopefully will be in a position at the end of April to set out a plan for May, June and beyond that, so that the various sectors can see in broad terms when they can expect to be opening all or parts of their businesses.
Okay, thanks a million, Ronan. Thanks, Chairman.
Thank you. Lorraine Clifford-Lee.
Thank you, Cahirlach, and like my colleagues, I'd like to express my gratitude to Dr. Glynn and his team for all the work that they've done over the past year or so. I just want to firstly ask about the stillbirths that have been connected with COVID, and we know that 7 cases of coronavirus-related infection of the placenta have been detected here in Ireland. Unfortunately, that resulted in 6 stillbirths and 1 baby being delivered by emergency C-section. Now, I believe that these 7 cases make up a third of the cases globally in relation to this particular issue. And would you have a view on why that rate of stillbirth is happening here in Ireland, or why is it being detected here in Ireland and not being detected in other countries? Because it's a very unusual pattern. And also on that point, I'd like to ask you if you will be making any recommendations in relation to the vaccination of pregnant women or any other measures that should be put in place given these very, very worrying findings.
Thanks. So to your first question as to why we've seen it here, or at least why we've reported it here. So there's a difference between seeing something and reporting it, and certainly we've always been very good at reporting it here. The reasons for this aren't entirely clear. What is clear is that they emerged in a period where we had a massive increase in incidence of the disease, and community transmission was widespread with the new variant. Beyond that, it's difficult at this point to identify the precise reasons why we've seen it here and other jurisdictions haven't yet reported it. But I think that's something that remains under investigation by colleagues in the Institute of Obstetrics and Gynecology and in the Women and Infants Programme and the HSC. But I suppose what I would want to do is to reassure women and indeed their partners that overall, the experience in this country around maternity care and COVID has been a very positive one. We've had no maternal deaths over the past year, and hopefully that will continue. What I would also say, though, in relation to women who've been diagnosed with COVID, is that they should make their medical practitioners aware of that and follow all the protocols that are in place around that. But to your second question, and sorry, which was about the issue of vaccination, so NIAC are keeping that under active review. Obviously, any woman who is at high risk or very high risk because of an underlying condition will already have been prioritised for vaccination. And beyond that, NIAC is keeping it under review. But I think it would be a significant move forward to decide to vaccinate all pregnant women on the basis of what is to date very limited, albeit concerning information. I think we need to collect more information both in Ireland and internationally in relation to the issue.
Okay, so just to be clear, these 7 cases are directly relating to the huge surge that we saw in December and January.
So I don't have the precise time points for all of those cases, but I know the majority have arisen in the context of the surge that commenced in December through January, February.
But you're of the belief that the reason we're seeing it or reporting it here in Ireland is that we had such a high level of community transmission down to a new variant at a particular point in time. You believe that that's probably the reason why we're seeing it and other countries aren't seeing it in such numbers?
No, I wouldn't go that far. I think the reason we're reporting it is that our colleagues in pathology have very assiduously followed up these cases and investigated them and reported them. Why other countries that have seen similar increases in or similar surges in disease have not reported this is a question that remains under investigation. It's not entirely clear.
Okay, thank you. I just want to ask a question about the pop-up walk-in centres, testing centres that have occurred over the past number of weeks, and we had one in Balbriggan in my own constituency. I want to ask you if you view these pop-up walk-in centres as a success. I'd like to know what the average positivity rate was in these centres, and if you've seen a reduction then in community transmission in these particular areas that would have had the walk-in centre prior to now. Thank you.
So I do regard them as a success, principally because they have afforded an opportunity for various stakeholders and various organisations in the
How are you doing?
In the communities concerned.
Conway needs to be muted.
Anyway, I want to do a €20.
Apologies, Martin Conway, you're on your phone there, please. Will you mute yourself?
So,
Okay, sorry, Ron.
That's fine. So I would regard them as a success, principally because they have raised awareness within the communities about the extent of disease in those communities and the need for people to come forward and get tested. Our public health colleagues in the HSE are very clear that they've had a positive impact. The challenge, I think, as we continue with them, and I think we certainly need to continue with them, is to ensure that local politicians, local stakeholders, local organisations get behind these each time they come round to the area, raise awareness, ensure that people know that they're there, the purpose of them, excuse me, and the people come forward and get tested. Your question on the average positivity, so I think there's been almost 30,000 people through the various centres since the end of March. There's been almost 800 positive cases identified to date, and the overall positivity is about 2.8%. So that will vary from site to site, but generally speaking, the positivity has been somewhere between 1.5 and 5.5.
And thank you for that. And could I just ask if you saw a reduction then in the community transmission, say with the very first wave of these pop-up centres? Have you seen a real difference then? Because I know you were targeting areas that had high incidence rates.
It's difficult to say that just yet because they've only been in place for, I think the earliest ones were put in place about 3 weeks ago. But certainly our public health colleagues in the HSE are saying that what they have seen is a very significant improvement in local level engagement and willingness for people to come forward more generally, and awareness amongst people in those communities to isolate and get tested if they do develop symptoms. So everything I'm seeing suggests that these have been a very positive development, and I think we need to continue with them over the weeks to come.
Perfect. And I just have one very quick question there. Do you expect the OR number to rise due to the Easter break and the schools all returning?
Professor Nolan may wish to come in on this, but I will say that we've been pleasantly surprised by the profile of the disease over the past week, but there is uncertainty around that because of the nature of the week that it was. We'll have to monitor it over the coming weeks. Our bigger concern, and again, there are people who don't want to hear this, but our bigger concern about the schools reopening is not so much the impact of what might happen in schools themselves on transmission or on the R number, but specifically that wider society will take it as a message that they can return to their workplaces, that they can return to other forms of mobility and social contact. And so we're really asking parents and guardians and others across society to please continue to work from home, because in the context of what we want to do more broadly as a society, and I understand many people would prefer to be in a workplace than be at home, but in the context of everything else we're trying to do, working from home is a really powerful thing that people can do to contribute to keeping this under control over the coming weeks. Professor Nolan may wish to come in.
Nothing much to add other than we can see a decreased attendance at workplaces as schools closed, and everybody understands why. So we won't necessarily see any increase in the incidence of disease, provided, as Dr. Glynn has pointed out, people don't take the return to school as an opportunity to return to the workplace. And the other positive thing that we're seeing in mobility data is a lot more outdoors activity. So if people read the signals well and get out and about for their socialisation and mental health rather than doing anything indoors, we could well keep the disease under control for the next couple of weeks with schools open.
Thank you very much to you both.
Thank you. Bernard? You're on mute.
I want to first of all congratulate all the team for the work that they have done, the coordination, the dedication, and the measure and the follow-up. To be fair to them, in very difficult circumstances where everybody has the answer, everybody points the finger, everybody says, how could be done better. Well, those in the eye of the storm are usually in the best position to be able to tell us how and better it can be done and when it can be better done. I would also like to compliment that very large cohort of Irish people who've observed the regulations to the letter. again and again and again, made the sacrifices, stayed indoors, stayed social distancing, and maintained. There was another minority of people, of course, who didn't. And of course, that is always the case. But I think that we, at this stage now, we have to look cold and hard at what lies ahead. In the period, in the next 4 or 5 or 6 weeks, there may be some indication of resurgence, especially in certain areas, and there may not. I don't know. What do we do, and what is the best thing to do in the event of an indication of resurgence of the virus in different locations throughout the country? That's the first question.
So again, Professor Nolan may wish to come in. I think there's two things I would say. First of all, we have this walk-in pop-up approach now that seems to be working well, and I think we need to continue to deploy that where there are issues of concern. The second is that increasingly we need to give further voice and more voice to our local public health colleagues on the ground. We have become the face of this response over the past year. The actual work being done and the people who really need to be thanked are the people who have been following up every case, every outbreak, all across the country in departments of public health, in the contact tracing centres, across all of the various elements of the response. But we really need to facilitate and empower our local public health leaders to come forward on local radio, on local media, so that people understand what's happening in their communities. The third bit, I suppose, to say that what we have seen time and again, and it reflects your earlier comments, is that the vast majority of people in this country understand what's going on with this disease. They understand when things are taking a turn for the worse. They listen to us when we voice our concerns. They might not want to hear the message, but they listen to the message. And generally speaking, time and again, when we've said, look, we're seeing a signal, we have increasing concern, please pull back a little bit, please decrease your social contact a little bit, people have responded to that time and time again at a population level. And that, more than anything else, is what has defined the response to this. And I think when this is all done, that more than anything else is what we should look back proudly on as a country, is the way people came together in communities in solidarity. And I think that will be the key to getting us to where we need to get to over the coming weeks and months.
Thank you. Can I ask further whether or not, for example, the worst case scenario that might visit us at this particular stage is to see an upsurge in infection again, and to see it continue, because the longer that continues, the more desperate it becomes, and the more disheartened the general public will become. So the point I'm trying to get at is to try to ensure that we don't allow it to continue. We have to make some intervention, crucial intervention, in the event of there being an unprecedented upsurge in the virus in the next 2, 3, 4, 5 or 6 weeks. What do we do?
I don't think anyone would ever accuse us of not having been forward about proposing measures when they were required over the past year. I sincerely hope that we will not be in that position. The things that people can do now, by and large, are very safe activities. Meeting up outside, travelling within the county for outdoor activities, our children going back to school in what have proven time and again to be low-risk environments. I have no doubt that it won't be straightforward over the next few weeks. We will have ups and downs, but we'll continue to respond to that. And again, ultimately, our local public health colleagues and the population more generally, I am confident will respond to that. And I am really hopeful we can keep this under control and get to where we need to in June and July and onwards from there.
Are you satisfied? Last question. Are you satisfied that you have in place the necessary measures or proposals to curtail any spread in a short space of time without bringing the whole country to a halt again as we go back into full lockdown again? And to what extent has that possibility been examined?
So we examine that possibility every week. That's a key part of the NEFIT analysis every week. And we can't exclude a possibility like that. And I know now that'll be the headline that I can't rule out a further lockdown. We're not predicting another lockdown. We do not want to go backwards with these measures. We'll have to respond robustly if we see an issue. And the key point in what we do or don't do, and the key point in whatever measures are eased through May and through June, is that we need to continue to keep a focus insofar as is possible on outdoor activities. And where there are indoor activities, that they are controlled and they avoid the criteria and the conditions that facilitate super spreader events. Because given the incidence that we have at the moment, it would only require a small number of super spreader events, and particularly a super spreader event or events with a variant, to get us into trouble. So we're in a very good position. We're the third best in Europe by incidence at the moment, and I'm hopeful we can stay there. But that's, there are uncertainties, and we just need to continue to review and respond.
Thank you. Professor Nolan, did you wish to comment on that?
No, Ronan's captured it perfectly.
Okay.
Thank you very much.
Thank you.
Thank you, Chairman.
Patter.
Gurmila Margaret Coherlick, I really do appreciate you giving me an opportunity to ask a question here today. And I'd like to thank our guests as well for the presentation, the information that they've provided for us. I suppose really the question that I wanted to ask was that today is the 198th day of workplace closure in this state. And if you compare and contrast the number of days and the length of time of our lockdowns and the severity of our lockdowns, they're significantly higher than any other European country at the moment. Now, I understand that the characteristics, obviously, in Ireland's health service, population, etc., is different than many other European countries. But it still remains the same that the policies chosen are radical outliers in international terms. And WHO has even said that lockdowns should not be the
So there was in the most recent advice, prior to the most recent advice to government, there was a full international analysis done of I think it was 18 neighbouring countries in relation to their approach. We're not out of line with their approach. The difference between us and those countries is that we had an enormous surge in December and January that we're still recovering from. The difference between us and those countries is that many of them are now undergoing an enormous surge, whilst we're in a much better position. So many of those countries, for example, their schools are closed at present. So I think, look, there'll be plenty of time for in-depth analysis when this is all done. I'm confident that if we can keep things positive and going in the right direction over the coming weeks, that the analysis of our epidemiological performance versus other countries will show that the measures that were taken were by and large the correct ones, and that's not for a second not taking account of the very, very significant impact this has had on various sectors within our economy in particular.
Just in relation to, like, for example, France have closed schools the 3 weeks around the Easter, but its schools had remained open since the start of September last year up until this particular break. And while the workplace closures is far longer, according to Reuters, for example, than our European comparators, there's very little difference between, let's say, morbidity and mortality rates between countries like Germany and Ireland. It's just, it's still, I do understand that waves have happened at different times, but in general, many countries have managed to lock down far less without the massive cost that we would imagine that would bring. And I just wanted to know, I suppose, the policies in Ireland are outliers with regards the European terms.
Look, I suppose we'll have to agree to disagree. I don't think in broad terms we're outliers in terms of the epidemiological performance. I mean, if you look at schools, I don't think anyone would argue that schools should have opened before they did, given what happened. I mean, what happened in December and January, and we had to respond to that in epidemiological terms. We didn't want to respond. The last thing we ever want to do is to give advice that schools shouldn't open, for example, or that businesses need to close. We understand no one wants to hear that, but at a point in time, looking at the data, looking at the morbidity, looking at the mortality, we give public health advice, and we accept at all times, and contrary again to to some perceptions, we give advice based on our assessment of the public health condition, and there are always wider considerations.
Just in relation to cancer services, heart disease.
Padder, you asked to come in for one question. You know.
Well, sorry, no, apologies. I thought I was going to get a couple of questions, Chair. Apologies.
No, there isn't time. Like we're
actually no, that's fine.
We're into
I appreciate
25. We're 5 minutes over the time we're supposed to go in. I haven't had the opportunity to ask any questions myself. You know, so you know, we don't have the time. So I need to finish up the meeting. So apologies to end on a negative note, but can I first of all, on behalf of the committee, thank our guests and apologise for the technical issues that we had in relation to today. I think there's some really good information that you've passed on to the committee today, particularly around the amount of deaths that are down. I just wonder, do we know why? Is it linked to the amount of cases that people are getting COVID? Maybe it might come back on that, but is it down to the hospitals getting more experience, medical staff getting more experience in dealing with COVID itself? I think there's really positive work. The initiative around the people who are asymptomatic, the introduction of the walk-in centres. I think we need to do more in relation to encouraging more people to use those centres, and again, it's probably a role not only for public reps, but the community to be involved in that. I'd be concerned that some areas, I know of one area in Dublin, there was something like 150 people used it, where you look at an area like Finglas and it was 6% of those, that were captured there was 6% that had COVID. So there's a lot of positive things. I just think the biggest concern we would have, many of us would have, is that we're losing people in relation to many of the restrictions, that people don't understand them. They don't know, so the logic of many of the restrictions, if you look at, we're allowing, where children are back in school, but if you look at the figures of those who were the outdoor transmission of COVID, and people say, well, you're allowing children back in school, but, they can't go out for a game of hurling in the air with their friends, whatever. So, those type of issues concern people. Bookshops, that you have some suppliers that are open, others aren't. There's a lot of issues out there that could probably be addressed, but I thank you for your work, and I think it's been really useful for the committee to get your feedback. And again, in relation to the modelling, we'd really appreciate if you could forward on that information in relation to that. So again, thank you and your colleagues. And I need to say that our next meeting then is going to be on. That concludes our business today. The meeting now stands adjourned until 3:30 next Tuesday, the 20th of April, where we'll get a briefing from the HSE and the National Immunisation Advisory Committee on the rollout of COVID-19 vaccine that we covered here today. So again, thank you all, and I look forward to meeting members at the private meeting this afternoon. Thank you very much.